Good afternoon, everyone. My name is Angelo Florimon. I am with Miss Lysandra Yu and Miss Helen Lam. And today we're going to be talking about our article, which is titled Diagnostic Utilities of Clinical Laboratory Data Determinations for a Patient with Severe COVID-19. Clinical support services and large HCO plays an important role in diagnosing and meeting patients' needs. Diagnosis services as a part of the CSS is an integral part of healthcare and its effectiveness during COVID-19 pandemic and is being analyzed in chosen articles. Our authors for today is Mr. Yang Gao, Mr. Tuan Lee, and Mr. Dong Yu. Mr. Yang Yao is an associate professor at the University of British Columbia School of Chemical and Biochemical Sciences. He has numerous publications that strongly focuses on biostudies and biomedicine. Next, we have Mr. Tuan Lee, who is currently employed at Fuyang Second People's Hospital Department of Internal Medicine. He received his medical degree at the University of NU Medical University in China, and this is his first publication. Lastly, we have Mr. Dong Wu, who received his degree at the University of Science and Technology of China. He is currently employed as a scientist, as a project scientist at NASA, and most of his publications are focused on diseases.
So the terminology on this chapter is about clinical support services. One area of the clinical support services is diagnostic service, which are give results to the physicians for them to diagnose. These results need to be accurate and effective when providing the results. The turnaround time needs to be short, and the test usually is cost effective, and they base the demand on the forecast patients visit times the number of service per visit. So the methodology that the researchers used in this research was that they choose a group of 43 patients from 19 years old to 70 years old, and they placed them in two groups: severe group of 15 and the mild group of was 28 patients in the mild group for COVID-19. They write the consent from each patient and everything. So then they collected the blood samples, and they did the following tests. The WBC, they did a cell count for WBCs. Inside these the lymphocytes, the monocytes, the neutrophils, and these are signs. This is to look for infection. So the level of liver enzymes. They studied for AST and ALT for liver function. They also look for the level of glucose, urea, creatinine, cysteine, and uric acid. They tested for C-reactive protein, the marker for inflammation response of the body. They did a coagulation profile. So they studied for the D-dimer, thrombin time, prothrombin time, fibrinogen, and they activated partial thromboplastin time, and all this is to study the clotting time of the blood. They also look for the levels of the procalcitonin to identify if the infection is due to bacteria or virus, and the interleukin-6 is part of the inflammatory response of the body. Okay, so as results of the blood tests, we want to point out the difference between the interleukin-6 and the D-dimer, who had statistically significant results because the level of the P is less than 0.05. So the levels of interleukin-6 was significantly higher in the severe group The severe group had 36 picograms per milliliter compared to the mild group with 10.60 um, with 10.60 picograms per milliliter. The D-dimer was also different between the severe group and the mild group of COVID patients, 0.49 compared to 0.21 micrograms per liter. So in the ROC curve, they this analysis to look for to predict the severity of the COVID onto the threshold, onto what point my markers are gonna show a severe pneumonia. So based on my markers that show that were statistically different, we have the interleukin-6 as the D-dimer. So the critical point in the interleukin-6 was the 24.3 picograms per milliliter. Until this point, we don't have a severe pneumonia. And for the dimer, the critical point was 0.28 nanograms per liter, and of that critical point, the patient didn't have severe pneumonia. This test had higher sensitivity for 73.3% and specificity of 89.3% for interleukin-6. And the results for the D-dimer, the sensitivity was even higher with 86.7% and specificity of 82.1%.
Overall, 15 out of 43 had severe COVID-19 and 28 out of 43 had mild COVID-19. Between the two groups, diabetes and chronic obstructive pulmonary disease showed significant difference. After reviewing the blood work of the patients, there were no difference in white blood cells, lymphocytes, mononuclear cells, neutrophil cells, alanine aminotransferase, cysteine, uric acid, ALTs, creatine, cysteine, uric acid, APTT, PT, and PCT. But the levels of glucose, the C-reactive protein, interleukin-6, thrombin, and fibrinogen, and D-diameter were significantly different from the severe group. As to whether we disagree, the sample size should have been larger. The evidence that were collected was proven through blood specimen and fluorescent reverse transcription polymerase change of COVID-19. The results were not falsified. It was reliable based off of comparing and contrasting. It was not one-sided. The high sensitivity and specificity of the clinical results demonstrate the accuracy of the test results. Also, it has given written permissions for the patients and also getting permission from the ethics committee of Fufang Second People's Hospital.
Results help a physician diagnosis a patient. Clinical labs and diagnosis services must present accurate and reliable results to support the healthcare givers. Blood work goes more in depth in helping to determine the problems. Results for a physician are critical in making the decision on the proper care that should be given to a patient. And even though this data cannot be used to set a threshold or on any test maker, physicians should focus more on the monitoring and co-arbitrating profile of patient tested with COVID-19. The relationship. So the collected data could be used, as previously stated, as a stepping stone in analyzing the data for patients that do have COVID-19. And based on the studies, Clinical laboratories can monitor specific markers for all the patients that are admitted for COVID, and collecting all this data and applying this analysis to differentiate the difference between patients that have mild COVID symptoms and patients that have severe COVID symptoms. And fast diagnosis of severe COVID symptom increase excellence of care, because when you're able to analyze the difference, you'll be able to provide better care for your patients, whether they do have mild COVID or they are extremely sick with COVID. In conclusion, our findings suggest that our interleukin 6 and D dimer levels can be used to estimate the severity of COVID-19. It is necessary the levels of the interleukin 6 and the D dimer should be measured to help diagnose the severity of adult that has COVID. Unfortunately, due to some limitation, one being the sample size being smaller compared with other categories, it is suggested that for future references, the data is collected from a larger group of people, ideally healthy patients, as blood control to further explore and predict the value of the interleukin 6 and D dimer for patient that has the infection. With that said, this is our presentation, and this is the link to the article if you guys want to check it out for yourself. I hope you guys have a great rest of your day. Thank you.